So, hello and good evening, everyone. Welcome to the 128th Blue Hills virtual seminar. This virtual seminar is a platform that allows healthcare profit different health-related topics for better patient care. Today's virtual seminar is brought to you by Blue Hills Ethiopia with International Society of Sexual Medicine as part of their Blue Hills Ethiopia is a medical consultancy company founded by medical doctors and a computer engineer, and we aim to be an influential healthcare leader in creating a skilled community. She is Lena, I'm your host, Dr. Ethiopia, and my international staff, Dr. Meskerem Teshome, here with us to have a presentation on prevention and response to sexual abuse. So, Dr. Meskerem Teshome is a consultant obstetrics and gynecologist at Addis Ababa University, Tukur Anbessa Specialized Hospital. She completed her medicine degree at Mekelle University and her specialty in obstetrics and gynecology at Yekkatit 12 Hospital Medical College.
Okay, thank you, Dr. Hino. Welcome, everyone, and thank you for joining this webinar on preventing and responding to sexual abuse. For many, this is unspoken reality covered in silence and stigma. Today, we are here to break this silence, and we will discuss on the practical aspects to prevent sexual abuse and what to do if it happens. So the objective of this webinar is first we will try to define sexual abuse and its forms. We will try to understand its cases, impacts, and magnitude, and also to explore prevention strategies. And also the webinar also tries to learn effective responsive approaches and to discuss Ethiopian context, the common challenges and opportunities that we practice here in our countries. The contents of the presentation. First, we will introduce about sexual assault definitions and the magnitude of the problem. Then we will proceed to evaluation of sexual assault survivors, what to do for these sexual survivors, and the response to sexual violence, role of healthcare providers, and at last we will try to see the prevention of this sexual violence. And finally, we have these reference questions, suggestions, and comments. So, as an introduction, sexual violence occurs throughout the world, and it is a serious public health problem affecting women's health. And globally, 1 in 3 women faces sexual violence in their lifetime, and it has profound impact on the physical, psychological, and the mental health of the victim. And there are several terms for this sexual violence and the related topics. One is gender-based violence. This gender-based violence is an umbrella term for any harmful act that is perpetrated against a person's will, and that is based on socially ascribed gender differences between male and female. Like this, sexual exploitation, sexual abuse, and sexual assault are particular forms of gender-based violence. And the other one is rape, and this rape means it is non-consensual sexual intercourse. In gender-based violence has physical, mental, and social abusive acts, attempt or threatened done with some types of force or manipulation and without the informed consent of the survivor. And the other term that we use is sexual assault. Sexual assault, it is an intentional act involving sex organs, and it also defined as any deliberate sexual act performed by one person on another without explicit consent. The other term is domestic violence, and this domestic violence is any incident of treating behavior, violence or abuse. It can be psychological, physical, sexual, or emotional abuse between adults who have been intimate partners, regardless of the gender. When we try to see the extent of the problem, gender-based violence or sexual violence is most widespread human rights abuses and public health problems in the world. And as we discussed earlier, it affects 1 in 3 women. And as you can see in this picture, most of the cases are are not disclosed because of shame, fear of blame, and the like. And sexual assault is considered as the most underreported violent crime. And around 30 to 50% of sexual assault survivors uh, didn't report their problem to the legal bodies and to the health cares. When we try to see the extent of problems in Ethiopia, among women aged 15 to 49, only 23% of them will report this problem. And from these women, around 23% of them have experienced physical violence, and 10% of them was sexual violence. And 4% of women have experienced physical violence during pregnancy. There are several studies, and there was one school-based study involving randomly selected females, around 1,400 high school students in the central Ethiopia. And from these students, around 74% of these has practiced several forms of sexual violence. Around 5% of them has completed rape, and attempt of rape reaches around 10%. And these numbers try to show you the figures of this sexual violence extent in our country. And this bar graph shows us the extent of problems here in our country. And as you can clearly see in this picture, around 71% of females has experienced sexual violence during their lifetime, including those physical violence and sexual violence. And this study was done in the Butajra, and among those women who has currently violent who experience physical violence within the past 12 months accounts around 54%. And having said it, when and where this violence, sexual violence is occur, gender-based violence can occur anywhere, at any time, by anyone. It's not only affect the victim, but also it involves the families, communities, and societies in general. And when we try to see the impacts of the sexual violence on the survivors, around 33 to 50% of survivors report suicidal attempts, and above 50% of rape survivors experience difficulty in reestablishing sexual and emotional relationship with their spouses or their boyfriends, and approximately 1% of injuries require hospitalization and major operating procedures, and up to 40% of survivors sustain several kinds of injuries. These are some of the health consequences of sexual violence. The fatal outcomes can be due to suicides or AIDS-related mortality or maternal mortality, and the non-fatal outcomes can be physical injuries due to chronic conditions like that of fractures, thoracic, abdominal injuries, and the like. And can also be sexual and reproductive sequelae like that of gynecologic disorders, infectious disease like that of pelvic inflammatory disease, sexually transmitted infections, HIV, and the like. And it's also have psychosocial health consequences like that of depression, anxiety, suicidal ideation, self-harm, and the like. And whenever we found these sexual violence survivors, we have to have this evaluation of prevent evaluation, and the evaluation of sexual violence are several objectives, and to diagnose accurately and manage physically, psychological, and social injury sustained during sexual assault. This physical evaluation should be well documented, and the objective of sexual violence evaluation is one is to diagnose and manage accurately. The other is to prevent potential problems resulting from sexual assault, such as pregnancies, sexual transmitted infections, and HIV/AIDS. The other one is to collect medical and forensic evidence that can be assisted the judicial process of obtaining justice during the assault. The other objective of this evaluation of sexual violence survivors is to refer for other necessary health cares, including legal, shelter, support, and the like. So having said it, whenever we are planned to have evaluation to this sexual violence, these are some of the settings that we have to have in order to evaluate this sexual violence, starting from the environment. Gender-based violence is a severe violation of women's and girls' rights, and therefore, in order to ensure these survivors receive adequate treatment and care, it's important for the healthcare workers to understand the importance of appropriate clinical management. And this starts from the responsibility of health actors to ensure that the health care workers are trained and the health facilities are accessible, secure, clean, and neat. So we need to have private and quiet rooms, and we also need to have chaperones, and only persons whom the survivor desires should be allowed in the room. And if the sexual violence survivor is a minor, the parents or guardian should be present whenever evaluating this minor or mentally retarded sexual violence survivors. So always we have to have this safety first, and you have to prepare private room to which unauthorized people do not access that rooms. So here are some of the equipment that is required in examination room. One is ethical, safe, and appropriate data collection method should be in place. Consent forms, supplies for the exams, and patient information forms should be available in each health facilities. And locked cabinets must be available to ensure confidentiality of patient records and the files. And the other equipment that we need is comprehensive gender-based violence kits, which includes anatomical correct dolls, must be available. And the other is this accessibility of healthcare providers who can have knowledge and attitude to evaluate these sexual violence survivors. And these are some of the responsibilities and obligations of the healthcare providers to provide appropriate and comprehensive, compassionate healthcare to all the survivors, irrespective of the age, class, sexual orientation, and race, ethnicity, and the like. And we have to be objective and free of bias or prejudice, and maintain high ethical standards in the provision of survivors of this sexual assault. And the other thing is any healthcare providers who is going to evaluate these sexual violence survivors have to promote and provide patient-centered care, and keep in mind that the diverse needs of the survivor. And the other thing is we have to have we have to respect the confidentiality of the survivor. The safety and the privacy requirements has to be there in all times. Mm. And the other thing is we have to obtain survivor's consent before performing the medical examination, including for laboratory investigations and treatment. In case where the survivor is a minor, consent should be given by parents or guardian, except where it might put the child in danger or otherwise be against his or her best interest. Uh, if we suspect that the perpetrator could be a parent or a guardian, so it has to be cautiously evaluated. And the other thing is we have to offer medical and forensic service in a way to minimize the number of uncomfortable and invasive physical examinations and interventions that the survivors would avoid. And the other thing that we need in our room is to record the details of the history, physical examination, and other relevant informations clearly. This helps to ensure accurate and objective documentation at all findings, and we have to keep this recording confidential. And the other thing is with the patient informed consent, we have to collect any forensic evidence that might be needed in subsequent legal actions. The other thing is this examiner of the survivors have to work with the communities to increase the awareness about the availability of the service. And whenever we provide this service to the sexual violence survivors, the following principles are fundamental. As we all know, whenever we treat any patient, there are ethical considerations, and the first one is to have this autonomy. This autonomy is the right of the patient, or in the case, the right of the survivors, uh, the right of the survivors and individuals in acting child. And the other ethical consideration is beneficence. Beneficence means that the duty or obligation to act in the best interest of the survivors or the sexual violent victims. And the other ethical consideration is non-maleficence. Non-maleficence means that with the duty of the obligation to avoid harms to the patients or the survivors. And the last ethical consideration is there has to be justice or fairness in every aspect of evaluation of these survivors. And as we can see in this picture, having after evaluation of these survivors, we have to have this, we have to give the adequate or appropriate clinical cares. We have to collect evidences for the legal bodies, and if this care is not provided in our center, referral has to be considered. And taking a detailed history of the incident, we have to perform thorough physical examination, head to toe physical examination, and document the findings clearly and accurately. And if there is any injury, and that must be treated in the evaluation of the patient for sexual transmitted infections, for any other preventive infection should also be assessed. And when it comes to the clinical assessment of survivors of gender-based violence or sexual violence, we have always we have to remember these 5 simple taxes, and it's put as an acronym, which is called the LIFES, and the L stands for listening. We have to listen to the woman closely with empathy and without judging. And the I stands for inquiry about the needs. We have to assess and respond to her various needs and concerns. It can be emotional, physical, social, or practical consent, like if she wants previous children care and the like. And V stands for validation. Validation means that we have to show her that we understand and believe us, and we assume her that it's not her fault that to be this sexual violence victim. And the other is enhancing safety, and to discuss a plan how she can protect herself from further harm if the violence occurs again. And the last one is to provide support by helping her to get information includes about the about the management of this sexual violence, and about the future outcomes that we are going to expect from these sexual violence victims. And these are some of the steps and consideration of this sexual violence evaluation. Before starting the history taking and any examination, we have to prepare the survivors. We have to introduce ourselves and explain the basic procedures that we are going to perform. And the survivors has to be calm, and we have to calm the survivors by saying to her that she can decline any examination if she doesn't want, and any investigations. And the other thing is, it's every health worker's duty to provide the best possible care to his or her patient, and therefore it's always every health worker's responsibility that the survivor gives her informed consent to necessary important investigations, physical examinations, and management. And the other thing is, the survivor has a complete right to request the presence of someone close to her. And when interviewing the survivor to take history, we have to keep a calm voice and let the survivor answers all the questions at their own pace. And we have to avoid repeating questions that have been asked and answered. And special attention have to be given to those survivors who has children or adolescents. And the other thing is, we have to ensure that the patient's demographic records like name, address, date of birth, sex, and place of the incident, and all the information has to be documented clearly. And we have to make sure that this information are secured, and we have to respect our client's autonomy. If possible, the client examination of sexual assault survivors should be conducted by a provider of the same sex. If this is not possible, a person of the same sex should accompany the survivors during the physical examination. And at the time of examination, we have to explain the survivors about experiencing physical symptoms like that of panic or anxiety, dizziness, shortness of breath, and the like is common. And we have to explain that these reactions are part of the feeling of strong emotions, and with this experience will eventually go away in a stepwise manner. You have to perform head-to-toe examinations of the patient to look any signs of injury and observe any records of changes of injury, including size, color, shape, estimation, and depth of aging or any healing injuries. We have to document those findings and in narration, or we can also put those on pictogram. And the other thing is, whenever we evaluate this sexual assault, we have to thoroughly evaluate the genitourinary systems, and hymenal examinations or anal examination should be done carefully after confirming that, informing the victim of what we will be doing. And we have to look for any bleedings, bruise, cut, abrasions, or redness or swelling in the legs. And whenever we examine this anal examination, we have to use your fingers for the sphincter examination and check for this patency. And timing of this physical examination is best performed soon after the survivor present to the health facility. And any delay in accessing health care service may result in loss of some of the physical findings and loss of some of the therapeutic opportunities, like that of provision of post-exposure prophylaxis, emergency contraceptives, and the likes. And the laboratory investigation has to be done as soon as the patient visits this clinic. And the other one is we have to collect forensic evidence if possible. And having said it, after we take the history and do physical examination and laboratory investigation, the next step is management of these survivors of sexual assault. And as you can see in this picture, this management involves three pillars. One is medical management, the other one is psychological care, and the other pillars of this sexual assault management are legal and social supports. And every sexual violence survivors need this management in general. And treatment will, especially this medical treatment will depend on how soon after the incident is the survivor present to the healthcare facilities. And for those survivors who present within the first 72 hours of the incidents, appropriate medical and surgical management for acute injuries has to be done. If there is any tear, we have to clean that tears, cuts, abrasions, and we have to remove those dirts. If there is any fissures or damaged or damaged tissue, has to be managed, and we have to decide if any wounds which need suturing or referral for further surgical care. And if the survivor presents within the first 72 hours, these are some of the things that we give as a prophylaxis. One is sexual transmitted infection prophylaxis, and for the adults, the recommended dose for this STI prophylaxis is to administer ceftriaxone 250 milligram IM or cefixime 400 milligram PO plus metronidazole 2 gram PO plus azithromycin 1 gram PO or doxycycline 100 milligram PO twice for those who has contraindication for doxycycline. We can give azithromycin, and for the pregnant women who has contraindication for this doxycycline and who couldn't take this azithromycin, erythromycin is also the options. And by giving this STI prophylaxis, this can cover the Neisseria gonorrhea, chlamydia, and also trichomoniasis vaginalis. And the other prophylaxis that we administer within the first 72 hours is HIV prophylaxis. And in the previous guidelines of this gender-based violence, the recommended regimen was to give them AZT, efavirenz, and 3TC. But nowadays, the current recommendation is to give them dolutegravir with tenofovir and mitriptyline combination or 1G regimen. Prophylaxis with these antiviral drugs for HIV following sexual assault is controversial. Despite this, most believe that HIV prophylaxis should be offered for sexual violence survivors and women who is at risk of acquisition of this HIV includes those perpetrators who is HIV infected or unknown HIV status. If the victim has been exposed to blood or semen through vagina, it can be through vaginal, anal, or oral intercourse, or through wounds or other mucous membrane. And the other risk is if the victim was unconscious and cannot remember what happened, and this the other high risk for this acquisition of HIV prophylaxis is if the survivors didn't remember what happened and if she is gang raped. These are some of the risks for the acquisition of this HIV. And the other prophylaxis that we administer is hepatitis B infection. And the CDC recommends post-exposure prophylaxis with only the vaccination without the immunoglobulin have these adequate protections. And those clients who take immunoglobulin are if the assailant was known to be hepatitis B surface antigen carrier, the immunoglobulin has also be recommended, and the vaccination can be given. The first dose can be given at the first visit, and the second dose can be given 1 or 2 months after the first visit, and the last or third dose is given 6 months after the second dose. And the other is tetanus prevention, and tetanus vaccination can be given with immunoglobulin or without. And for the indication for to give this tetanus administration is if the woman or if the victims has no history of tetanus vaccination, and or if she is not uncertain about the previous vaccination history of her tetanus, and if the wounds are dirty, or if she presents within the first 6 hours of the injury, tetanus vaccination is recommended. But for those who presents after 72 hours of this injury, tetanus vaccination is not recommended. And the other thing that we have to do whenever we found a survivor of sexual violence is to administer pregnancy prevention. And these four drugs. These are some of the methods that we use for pregnancy prevention, and the most effective one is to administer uripristal acetate 30 milligram. It is a one-time administration, and it can be given within 5 days of this sexual assault. And the other one is we can also give levonorgestrel administration by either repeat doses which contains 0.75 milligram or single dose which contains 1.5 milligram. And the other one is administration of this combined oral contraceptives or USP method. And this combined oral contraceptive have to have contain 100 microgram ethinyl estradiol and 0.5 milligram levonorgestrel. And the preferred one is, and the most effective pregnancy prevention is to administer copper intrauterine device. And the other thing that we administer if the survivor presents after 72 hours of the incident is to provide clear information so that they understand the options if they becomes pregnant, like that of ANC, adoption, foster centers, abortion services, and the like. And if the survivors present after 72 hours, STI treatment is warranted. And if the patient are only warranted for those who has laboratory evidence of the infection, or if the patient has symptoms of sexual transmitted infection. And after 72 hours, post-exposure prophylaxis is not recommended. Rather, we have to have this test of, we have to test them for HIV, and this may help on the subsequent legal process and subsequent management. And the other issue is, after addressing this medical issue, the other issue that we have to address is the social issues. And the survivor is not to blame for what happened. And her safety is is our priority, and we have to go through the safety plans on case by case, and we have to keep in mind that different needs of each survivors, and discuss the protection from further violence. In creating a safety plan, action plan steps need to be identified to increase the survivor safety and to prepare for the possibility of further violence. And we have to ask the survivors whether she has got a safe place to go, and we have to make sure that if someone she trusts would accompany her, and we have to provide a resource list of organization who can provide support in a social psychosocial support in a legal way, or other assistance like that of Association of Women's Equality and Development and Integrated Family Service. These are some of the examples of the organizations that we can link these sexual violence survivors. And always, whenever we have this sexual violence, who has minor or who is adolescent age, all children have to be examined by pediatrician or possibly pediatrician or mental health providers to assess needs for the treatment and to measure the level of parental support. And the other pillars of management of this sexual violence is psychosocial support. And these sexual violence victims require extensive emotional support and should be offered mental health service. And for effective counseling, you have to be professional, ethical, non-judgmental, respectful, and understanding. We have to guarantee confidentiality to the survivors, and we have to know and understand the psychological and social consequences that the survivors may face. And this psychosocial support includes trauma counseling, peer support groups, school reintegration, family counseling to reduce stigma. We have to provide supports to the victim in identifying support groups, legal groups, and mental health counselors. And the other burning issue is we have to address this stigma and victim blaming. We have to emphasize the importance of addressing stigma and victim blaming by helping these sexual violence survivors, and we have to challenge harmful attitudes. We have to promote empathy and understanding, and encouraging open dialogues with the families and with the societies and the communities are encouraged. And the other pillars of the management of these sexual violence survivors is legal protection and response. As healthcare providers, we have the responsibility to report any case of gender-based violence to the responsible legal bodies. And Ethiopian Criminal Code includes provisions that criminalize various forms of sexual violence, including rape, sexual assault, and other related offenses. So you have to report any forms of sexual violence that we face during our day-to-day activities. And if we are not trained about the evaluation of these sexual violence survivors, referral pathway in the linking service have to be prepared for this violence. And the other thing is this one-stop center. These one-stop centers are centers who has this medical professional, legal bodies, and psychosocial support providers. And we have, if possible, one-stop centers providing this one-stop shop clinic centers is encouraged. And these are some of the schedule of follow-up of evaluation. In our guideline, schedule follow-up is at 2 weeks, 6 weeks, and 12 weeks of after the initial visit. And we have to explain that follow-up visits are important for confirmatory laboratory diagnosis and to examine the treatment compliance and progress of the patient's physical and mental health status, and to address any additional complaints not adequately addressed in the first visit. Follow-up visit is also an opportunity to discuss the use of other services like social psychological services, emotional supports, and the likes. And additional to these follow-up visits can be scheduled according to the individual needs or the providers, the healthcare providers' concern. So when we see things that we do on these follow-up visits, on the 2 weeks visit or on the first visit, we have to conduct thorough physical history taking and physical examination and laboratory investigations. And also we have to assure that medication are being taken as prescribed and we monitor side effects of these medications. And if there are any concerns about the survivor safety, that has to be addressed. And the findings are documented and they have to be keep recorded in the confidential place. On the 2 weeks visit, screening of pregnancy has to be done, and conduction of pre-clinical evaluation to assess changes to previous findings, if there is any concerning issue in the previous visit, it has to be addressed in the 2 weeks visit. And by the 2 weeks, antibiotics course has to be completed, and screening for STI and treatment has to be done in the second visit for those who's not taking prophylaxis on the first visit and the initial visit. And the other things that we do on the second visit is to assess emotional and mental status and to treat or refer as appropriate. And if PEP is provided in the initial visit, we have to evaluate for adherence and side effects of these drugs, and we have to make sure that the survivors has complete adherence to these drugs. And the next visit after the 2 weeks is a 6 week visit. And at this stage, all the medication should have been completed. And we have to ask about compliance overall with post-exposure prophylaxis, and pregnancy test should be repeated at 6 weeks. And screening for CST can be done, and also emotional assessment. And any psychosocial support can also be given at this 6 week. And the last visit is at 3 months or at 12 weeks. And these are some of the things that we do at 3 months. Emotional status assessment, repeats of this serum tests for the RPR or VDRL, repeat serum tests for HIV at 3 months, and the next will be at 6 months. And we have to assess emotional and mental status, and community service also has to be addressed. Having said this, who can give this evaluation for the sexual violence survivors? In our guideline, it's recommended that general medical practitioner as well as a specialist should provide the care without the need for specific training. But for those with mid-level healthcare providers, they need to have specific training, and after having that training, they can have this certificate, and they can evaluate these sexual violence survivors. As a physician, we have these roles. One is to work in conjunction with a trained person to provide support and resources, to maintain professionalism and good working relationship, and for those who's interested to do research regardless of gender-based violence, and contributing for the sustainable solutions. The other thing is this legal obligations of the healthcare providers. as healthcare providers, after giving this care for the sexual violence survivors, everything has to be recorded accurately, and the injury has to be documented, preferably with diagrams, and collect sample to be sent for the forensic examination whenever possible. And we have to provide medical legal certificate using reporting format upon requesting from the legal authorities. And additional information collected methods such as photography, videography, and other available documentations means should be taken with the consent of the survivor. The other thing is, if this care is not provided in our center, we have to consider referral or linkage, and network services are very important to facilitate this sexual violence survivors access to healthcare and in available specialized service. And the ultimate goal is to recovery and empowerment in the reintegration of the survivors into the society. In a few exceptional cases where the life of the woman or girl is at risk, like that of if she has high risk for suicidal ideation, and if she's threat of being killed, or if she is prone to childhood marriage, it may be justified that referral unintentional unintended by a family member or agency without the consent of the survivor. And apart from this, we always need to have consent of the survivors. If referral is not possible, schedule follow-up appointment and provide necessary intervention until a referral is possible, or always use a referral form for referring out cases. And this is a wheel of intervention for the survivors, and this shows that centering the survivors of this sexual violence is crucial, and that her individual needs should be recognized when linking her to appropriate referral services. Linkage can be made through self-referral by health facilities or through a different service such as the police or legal bodies. And the other very important thing is the issue of documentations. We have to document each findings, and reporting is appropriate, and healthcare providers must often answer questions from the police, lawyers, or the courts about the injury occurred to the survivors that they have treated, and careful documentation of the finding and treatment on the history and exam forms will make it easier to give accurate and objective answers. And patient record and information are strictly confidential, and it has to be stored in a safe place. And all healthcare providers have professional, legal, and ethical duty to maintain and respect patient confidentiality. The other thing is this monitoring and evaluation. Monitoring and evaluation of this intervention will contribute to maintain or even improving the quality of the clinical management of the survivor for such violence by better assessing their needs and identifying and bridging capacity and knowledge gaps of the health workers. And these are some of special communities when we discuss to these sexual violence survivors. One is elderly women. After menopause, women experience decreased hormonal level, which results in reduced vaginal lubrication and thinning and fragile vaginal wall. So, when older women are exposed to this sexual violence, they are especially at risk of vaginal tears, injuries, and also they are more at risk of being infected with sexual transmitted infections and HIV. The other special population is dealing with this sexual violence are those with physical and mental disabilities. This group of women has specific health and medical needs, and special attention must also be given to this physical accessibility of these services. For example, those with hearing or visual impairments must be provided with appropriate means of communication. And the other special community is children's. When providing healthcare service, the children's survivors has to be with their parents, so with their legal guardians, and healthcare workers must ensure that a child-friendly and safe environment has there. And the other special populations are these adolescents. And when providing healthcare service for girls and adolescent survivors of sexual violence, healthcare providers must adapt their provision of service in order to address their special needs. Service for adolescent survivors should be confidential, and parental consent should not be required. And the other special population with this sexual violence survivors are homeless children, refugees, intentionally displaced women, and girls, because these populations are at high risk of this repeated sexual violence and at high risk of acquiring these sexual transmitted infections, and they are at high risk of this economic burden. So, having said this, let's come to the preventive strategies. And this preventive strategies has primary prevention, secondary and tertiary prevention. And primary prevention mainly centers on those things that may increase our awareness. And then secondary prevention is after this sexual violence is happening. We have to have this early detection and safe reporting. And the tertiary prevention more mainly focused on the survivor's care and rehabilitation. So the first one is as a primary prevention. We have to create awareness by creating campaigns, training throughout the communities, and having been significant efforts to address challenges and negative social and traditional perspective and transform gender norms that harm women and girls. We have to open communications and consent educations. And in our country, the health extension workers and the health development army play a crucial role in these effects. And the health extension program was established with the objective to provide cost-effective and essential promotion and prevention service for this sexual violence. And the other one is child protection laws and the policies provision. In this legal framework for protecting children from harm has to be there as a primary prevention. And the other thing that included this primary prevention is effective reporting and response system. And the other thing is to have this role of the social workers, law enforcement, and this the work that is done by the healthcare extension workers is very crucial and very important. And we have to train the communities in order to report whenever they have experienced or they have witnessed this sexual violence. The other thing is this empowerment of the women and the girls. It's very essential for prevention of this sexual violence. When women and the girls have access to education and economic opportunities and healthcare opportunities, they are less vulnerable to abuse. And also, women and the girls are empowered to speak out against abuse, and they can change the society and they can challenge the culture of silence. And the other thing is, it's better to link them with the support of the survivors organizations. And the other thing is to involve men and women in order to challenge these harmful masculinities. Men and boys have critical role to play in creating a culture of respect and non-violence. And we need to challenge harmful masculinities and promote healthy relationships. And we need to encourage men and boys to be actively engaged and speak out against abuse. And if you see something, say something, and don't be afraid to challenge. And you have to encourage those boys and men to actively engage on the activities against gender-based violence. And the other primary prevention is community-based prevention, and community and the religious leaders have significant influence on the community norms and values. They can use their positions to promote respect and equality, and they have encouraged community-based initiatives that address the root cause of the violence, and also dialogues with collaboration with the community and the society is encouraged in creating awareness. And these are some of the secondary prevention methods after this sexual violence has occurred. Responding to disclose this act is very important, and we have to emphasize that the first response to disclosure of the sexual abuse is very critical. And the ways that we respond can have significant impact on the survivor's healing process. And survivors are often afraid to disclose the abuse, and it takes courage to come forward. And believing them is essential for building trust and providing support. And the other the other important thing is we have to take steps to protect them from further harm. And if abuser is a family or member or caregiver, we have to remove the child from these situations, and we have to provide emotional support. We have to listen to them without judgment, offer reassurance, and validate their experience. And these are some of the reporting mechanisms in our country. Information has to be provided on how to report sexual abuse to the appropriate authorities. And here in our country, these appropriate authorities are police officers, social services, child protection agencies, and addresses that barriers. Some of these reporting mechanism includes those of stigma, fear and lack of trust, and we have to improve reporting and whistleblower protection. And the other thing is access to support, and it's important to provide survivors of sexual abuse with access to comprehensive supportive services, including counseling, medical care, legal aid, shelter support groups, and the like, and trauma-informed care by a trained person to avoid re-traumatizing of the survivors, and legal framework has to be there. Uh, as we all know, while Ethiopia has made some progress in addressing this gender-based violence, significant barriers remain that hinders effective prevention and response efforts. And understanding this is essential for developing targeted intervention and strategies. And some of the barriers include stigma, lack of trained professional, limited forensic and medical service, cultural acceptance of the violence, and economic dependence of the woman. And while we have discussed the challenges, it's crucial to also mention the promising work that's being done in our country. One promising area is the establishment of a one-stop shop, and this one-stop shop centers in different hospitals so that the survivors can get integrated service, including the legal psychosocial support in one visit at the one-stop center. And another important area is establishment of community child protections and commitments and school-based clubs, which help us to create awareness among these child and adolescent groups. And as we all know, prevention and response to sexual violence is not responsibility for any single groups or organizations, and it requires coordinated effort from all stakeholders. And this slide outlines the key roles that different stakeholders can play, like families, schools, health sector, policies, government agencies, and NGO has to take their role in order to prevent and respond to this sexual violence. And these are some of call to actions. One is to strengthen the reporting pathways, to train professional, to expand one-stop centers, and also to challenge harmful norms and empower the survivors. And the Ministry of Health stated core principles on response to violence against women and children in Ethiopia. And the general principle, it includes one is a rights-based and victim-centered approach. The other general principle that is stated by Ministry of Health is to advance gender equality and women's empowerment and cultural and age-appropriate and sensitive service. And the other is to give safety and appropriate care for these gender-based violence survivors. And the ministry has some strategic focus areas. One is to promote friendly environment for the survivors at the community level and engaging the community in the risk reduction and the response to gender-based violence. And by this can be done by creating awareness on prevention and early access to health care. And the other is to create an equitable health systems in the health response of gender-based violence. And this can enhance governance, accountability, and the regulatory framework, improve access to health service through expanding one-stop centers. The other ministry focused areas is to improve competency of healthcare workers for prevention and response to these sexual violence survivors. And the other is to improve availability and logistic supplies, to improve research and to strengthen the healthcare infrastructures. And also the ministry also has the stated that to strengthen multi-sectoral collaboration and partnership, and finally to create joint resource mobilization for effective health response for these sexual violence survivors. And as we conclude this webinar, I want to leave you with a sense of hope and call to action. Let us commit to challenge harmful norms, supporting survivors, and build a society where everyone is safe and respected and free of violence. These are my references, and thank you for your time.
All right. Thank you very much, Dr. Meskerem. It was a very great presentation, and we can now move to the question and answer section. So participants have been writing some questions in the chat box, so you can select questions that you believe are relevant and address them. So questions related to psychological support and mental health examination for such patients. There will be a webinar dedicated to that in the coming weeks, so we can skip those questions for now. So, Dr. Meskerem, can you access the chat box?
Yes, but I couldn't see any question coming from the participants.
Doctor? Sorry. Dr. Meskerem?
Yes, I'm listening. I'm waiting for the questions.
Oh, okay. So shall I read them?
Okay.
Okay, one question by Tasfay Asafa is what types of forensic evidence might be helpful? Do you give some examples?
Okay. So the forensic evidence that is taken for whenever evaluating these sexual violence survivors is during the physical examinations, if there is any seminal fluid from the vagina or from the anal canal or from the mouth of the survivors, this is one of the forensic evidence. And the other thing is if there is any remnants of the assailant, like that of the hairs, nails, and any fingerprints that can be identified from the sexual violence survivors. It can also be used as a forensic evidence. Am I clear?
Oh, yes, you're clear. Thank you very much. So another question is the hepatitis prophylaxis available and free for gender-based violence victims in the one-stop facilities in our country?
Okay, currently it's not available, and initially the one-stop center was established in 5 institutions, and on these 5 institutions, the other all the prophylaxis are available, but due to these economic issues, this hepatitis B immunoglobulin and vaccine were not available in these institutions.
Okay. So one question says, evaluation and management of gender-based violence survivors, should it be done at the one-stop clinics only?
Okay. In our what the guideline stated was initially it has to be preferably done to be preferably done on one-stop shop clinic. But for those institution who doesn't have this one-stop shop clinics, if the gynecologist or general practitioner is available, or if someone who's trained on this sexual violence survivors care are available, it can also be evaluated by those persons, and this one-stop shop is not necessarily for every survivors.
Okay, thank you very much. One other question states, can we save visual documents or photos as part of evidence depending on the victim's consent?
Yes, and what our guideline stated was if the examiner or if the evaluator has access for this video or photo with the victim's consent, it is one of evidence for the legal body. So, having pictures and videotape this evidence is recommended. But there has to be only with the consent of the survivor.
Right, thank you very much, doctor. So let me select one or two last questions and we can end the webinar. So another question by Mahalet Solomon is, how does a healthcare provider take consent from the patient's guardians of a minor if the parents are suspected to be the ones assaulting?
Okay, what our guideline stated was if you are suspecting the parents or the guardians who accompany the sexual violence survivors are who the perpetrators, we have to have, we don't consent them. Rather, as illegal body, the physician or the one who's attending this, who's evaluating these sexual violence survivors would do in the best profit for the survivors, and we don't take consent from those assassins or from the guardians, and any information that we identify from their parents has to be documented, and it has to be transferred for the legal bodies. And in this case, we don't take consents from the families or from the assassins that we suspect they may cause this sexual violence.
Okay, another question by Yamsrat.
By the way, it's one of the exceptions. I think I mentioned them on the webinars, and it's one of the exceptions that we don't take consents. Okay, the other question that you said was?
Okay, sorry. Is the same steps applied if the victim is a boy or a male?
And the physical history taking are almost the same, but on the physical examination, there were pictogram representations of the male genitalia and the female genitalia, and for the male survivors. And usually, what we practiced was to put those injured area, abrasion, and any physical findings on those pictograms. So those pictograms for male survivors is different. And apart from that, most of the management are similar to that of the women survivor, except those with actually, obviously, with pregnancy prevention. The other managements are almost similar.
Okay, one last question related to the previous one is, when we are saying gender-based violence, is it only for females or any report for men?
Around, pardon. So gender-based violence, it's as I discussed earlier, it's an umbrella term, and it includes this sexual exploitation, sexual abuse, and all in despite the gender. And it can also be occurred on the males, on the females, and it doesn't only mean that females are the victims.
Okay, I think we are almost done with almost every question, and yeah, we can end it here. So, on behalf of Blue Health Ethiopia and all our participants, and also International Society of Sexual Medicine, I would love to thank you for taking the time to present on a very important topic. So thank you very much, and we hope to be getting you in future sessions with different and related topics. So thank you very much. If you have any last remarks that you want to add, please let me give you the chance one more time.
Thank you for having me.